All right, we're good. All right, George, I'm going to make you host again.
Hey, George, just for kicks, now that you're host again, could you look under captioning and see if there is a save to the recording or have caption saved to the recording? Is that even a selectable item under that?
No.
Okay, I'll look into
I'm
this.
looking at the settings. I'm looking at the settings now, but
Okay,
I don't
excellent.
actually see. I don't see anything.
It would be under probably accessibility, more than likely, under settings, but I'm not sure.
Yeah, it just shows.
I don't want to bog you down on this. I've got some homework next week on this, so I'll dig into it pretty hard next week.
Okay.
Excellent.
And George, if you could make me co-host, please.
Oh, sorry.
And one thing we have done in the past is we've had the captioner as a co-host. It appears that it's not necessarily because captioning is working. So I just want to note that that is not a necessary step.
All right, I'm going to stand by.
And George, a friendly reminder, record at the appropriate time.
Thanks, David. Good afternoon, those of you who've just joined us. It's George here. We'll get started in just a few minutes. This is the training work group meeting for the Alzheimer's Disease and Related Disorders Commission. We'll get started.
Hey, George, Rick here.
Hi, Rick. How are you?
I'm good. I'm surprised you can't see me. I'm doing. I got the camera. I'm sitting in front of it. So, oh wait, let me see. Oh, there we go. Okay.
And I just want to remind everybody that we are streaming live to YouTube, and also this meeting is going to be recorded. And Rick, I have a few housekeeping announcements that I'll start with, if that's all right. We'll turn it
Sure,
over to you.
absolutely. Are you in Richmond or are you at home?
I'm in Charlottesville.
Oh, good. How's the weather in Charlottesville today?
It's chilly.
Yeah, here too.
Yeah. The weekend was pretty gorgeous there.
Yes, looking forward to it.
Hi, Rick and George. It's Vicki Armstrong. How are you doing?
Hey, Vicki.
Hi, Vicki. Doing well.
Great to hear your voice.
Yeah, how's retirement, Rick?
I'm enjoying it greatly.
Good for you. I was actually trying to figure out why you can't see my video.
I noticed on mine in the bottom left corner, there was something that says click to start video. See if you've got that.
Okay, yeah, I don't see that. Wait a minute, maybe. Yeah, video's not cooperating, but
Okay.
I'm not sure why. I'm trying to troubleshoot, but
There's Kim.
hi, Kim.
Kim, you are muted.
I noticed. Hi,
There you go.
Rick.
Hey, how are you?
Great. How are you?
Really good. Thank you.
Good. So impressive. You have your office with a video and
I moved into the 21st century. Took me a while.
no, you're doing it. We let you loose and here you go.
Do you know if Denise is
well,
going to be on?
She may be in memory care.
Okay.
clinic,
Okay.
but she'll try. Vicky's on.
I am. Hi, Kim.
Hi.
Denise has just arrived.
Well, good.
Okay. Wait, I think she was doing a TIPA today.
There's a second too. Okay, so why don't we go ahead and get started? I know there's a couple of people that may still join us. Laura Bowser won't be here today. So welcome to the postponed meeting of the training work group of the Alzheimer's Disease and Related Disorders Commission. I'm George Worthington, the Dementia Services Coordinator at the Department for Aging and Rehabilitative Services and staff to this work group. So I'm just going to start with some housekeeping announcements, and then I'll turn it over to our chair, Rick Jackson. Due to the active state of emergency, this is an electronic meeting pursuant to item 4-0.01 of the 2020 Appropriation Act. Meeting notice has been provided. The meeting is being recorded and minutes are being taken. All votes will be conducted via a roll call of voting members. Meeting materials are posted under the Alzheimer's Disease and Related Disorders Commission's work group tab at the link posted on the slides. Actually, it's on the agenda. Members of the public are able to live stream this meeting via the DARS YouTube page. Please be advised that if the live stream is interrupted, we will need to pause the meeting until it is restored. Public comment will be accepted by email or phone to my attention. Public comments that were received by yesterday will be read, or if lengthy, summarized during the meeting when we reach that agenda item. For the Zoom, so members, you probably are all aware of how Zoom works by now, but please keep your microphone on mute unless you're speaking, as this helps reduce background noise. Also, before you speak, please state your name. Not only does this help your colleagues know who is talking, but it also helps with documenting the minutes and the captions. Members, if you have your video enabled, please be aware the system may capture your image and video in the public streaming and recording. Use the chat feature only for technical issues, as the text in the chat will not be visible to members of the public, so please don't use it to ask or answer questions related to the business of the work group. You may also use reactions to do a thumbs up for agreement or clap to raise your hand, but again, remember that these are not captured on the recording. If you'd like to view the real-time captioning of today's meeting, please click on the CC button on the menu bar at the bottom and select Show Subtitles. Zoom participants will have to turn on their closed captioning. The YouTube streaming will automatically include it. The view options are towards the right of your screen, and you put those yourself. And for all votes, we'll do a roll call, and you will be asked to indicate your support, yay or yes, opposition, nay or no, or abstain. Lastly, I would like to thank the DARS video teleconferencing team and the DARS communication team for making this electronic meeting possible. So I'll just do a roll call to confirm attendance. Just bear with me a second while I pull up the agenda. Okay. Rick Jackson?
Here.
Karen Garner, Chesley Williams, she's not here, Kim Kuttner,
Present.
Laura Bowser, St. Herbert Gretz, Denise Butler.
Denise, you may be muted.
I'm muted. I just realized that. Sorry. Yeah, I'm here.
Great, thank you. And Vicki Armstrong.
I am here.
Super. Okay, so with that, I will turn it over to you, Rick.
Thank you, George. Thank you, everyone, for taking time out of your very busy day to join us for this most important work group. I think we all know each other, so maybe I will dispense with introductions and how you came. This is to this group, and unless there's a new member. There's not a new member, is there? Okay, so
There's not.
Yes. So if you look at the agenda, you'll see that the first item of business is to, in fact, adopt the agenda. So now that you've seen it, if we could get everyone who agrees to use this agenda for today's meeting, simply to say aye. Kim?
Kim, I.
Or
Yay.
no? Denise? Yep.
Aye.
And obviously George is on. Okay. Anyone opposed to
And
using
Vicki?
this agenda? Hearing none, we'll use this agenda. The next item on the agenda is the minutes from the July 29 meeting, which I hope you have in front of you and that you've received earlier so that you could review them. If not, we'll take a moment for you to look at them. I was looking at them this morning, and it was a good reminder of what it was we did on the 29th. Some of the things we looked at, some of the things that we have suggested for next steps. So are there any edits to these minutes or corrections? If not, could I get a motion to accept them?
This is Kim, I
Rick,
move we accept.
you can just adopt them.
Okay, so unless there's opposition, hearing none, we will adopt these minutes from the July 29 meeting. So George, it looks like there's opportunity for public comment here. Did you receive any?
I did not.
Okay. So skipping over that, moving past that, the next item on the agenda was to review draft training package for primary care providers. You'll remember
Yes,
it. Go ahead.
I was going to say you actually haven't seen this yet, so let me just share it. And I'm sorry, Rick, if you want to.
Oh, that's okay.
Okay. So can you see? Do you mind if I kind of talk through this?
Go right ahead.
Okay. Are you able to see this dementia resources for primary care providers?
Yes.
So, yes. Okay, good.
Everyone else? Yeah.
Okay. So what I've done is taking the discussion from the meeting last time. I've kind of pulled this together into a brochure. And I'm going to talk you through the brochure, but actually before we get into that, I'm going to talk to you about some kind of bigger picture things that I've been talking about with the other two work groups, because as I was putting all the work group agendas together and listening to the conversations, it struck me that we were all working on some sort of product or package or opportunity that that it seemed to me would be really great to have a unified branding for all of that. So we've discussed it, and the other two work groups have met already, and we had a discussion about it. This is going to be on the agenda at the next commission meeting. So what we've come up with so far is, you'll see down here, Dementia Capable Virginia, an initiative of the Alzheimer's Disease and Related Disorders Commission and DARS. So that's the kind of working title right now, the Dementia Capable Virginia. It'd be great to have something maybe a little snappier, but at least this kind of says what we're doing. And there's a whole, so what we're doing in this work group around the materials and training for primary care providers kind of works well with what what the other groups are working on. So the coordinated care work group is working on a resource for consumers, and the data and research work group is working on a forum for researchers to kind of pick up where the Virginia Neuroscience Initiative left off. But ours, what we've been working on here was the one that really gave me this idea, because we have so many different things that we're kind of pulling under one umbrella. So whether that's the micro-learning. So what I've done here is kind of divided up what we talked about last meeting into 3 different buckets: the training, resources, and referrals. And so I thought, I mean, maybe we won't actually use a pamphlet, but I just thought, well, this is something that you could hand a primary care provider's office, and it would list all the various things that we have available for them, whether they're on All's Possible or elsewhere. So with the training, I've kind of focused on the screening tools that we discussed a little bit last time, and also the micro-learning modules, which are really about the diagnosis and then moving on beyond the diagnosis. So I think that's kind of chronological there. Under resources, these are the dementia care practice protocol and after a diagnosis and coordinating dementia care. Those were those 3 documents that Dementia Friendly America, well, actually Act on Alzheimer's had developed. And then there's also some videos on care coordination that were on the Dementia Friendly America website, which are also Act on Alzheimer's products that I think would fit in well here. And then finally, under referrals, so that's about connecting patients with the appropriate services and supports. So we have the community organization practice tool, which really gets people thinking about the different things that people might use for or might need to be connected with. The Dementia Roadmap, which is the product that the Coordinated Care Workgroup is working on, the Alzheimer's Association number, and your area agency and Virginia Navigator. So there's probably many more things that we can add in here at some point, but I just wanted to put something together to give you an idea of how everything kind of fits together. And the formatting and everything is terrible, so please don't go by that so much as the content. So I've got some high-level things that I'd like you to be thinking about ahead of the next commission meeting, which is on December 8th, yes. So one is the branding. So if you have some ideas about maybe a better name than Dementia Capable Virginia, or some other ideas around that, if you have some ideas straight away, you can tell me now. Otherwise, we'll be having a full commission discussion on December 8th, so you can think about it then. The other thing we need to kind of think about for all of these everything under this initiative is marketing. And so some things are going to be amenable to doing a webinar or in-person presentations. We have lots of emailing opportunities that we can use to get the word out as well. But I think some of this, particularly what we're doing in this work group, is going to be really amenable to word of mouth and recommendations from other physicians. So again, if you have some thoughts about marketing, I'm just going to throw all of this out here at the beginning, and then we can do a discussion if that's okay. The other high-level thing is the training modalities, and we had discussed this in our last meeting, and I think the consensus seemed to be that we would use a mix of different training modalities, because some will suit some people and some won't, and so we want to have things that will be accessible for people and fit how they learn. So we have the micro-learning, we have opportunities to do some in-person training, whether that's by myself or somebody from the AAA or the Alzheimer's Association. We can maybe do some virtual sessions, and so that would be a virtual training session, and then on-demand webinars. So I think we'll probably end up using all of those things, frankly. But if there's anything that I've missed that might be helpful, please let me know. And then ways to do outreach. So the simplest way is probably going to be to contact health systems directly, but it would be really helpful to have, some names of the people that would be best to start with, and then professional bodies. So, so we can get the word out. Those are the two kind of easiest or most obvious ways, I thought, and there's plenty of others. So I'm looking for suggestions there. And then finally, tying all this together is the BOLD Act. So I'm going to kind of combine these two agenda items, if that's all right. That is next. But I'm going to switch my sharing again. So I know this is a little small. Let me expand that a bit. So in the BOLD Act grant, so you're all aware that Virginia Department of Health received one of the BOLD Act grants, and DARS and the Commission are key partners in that. So there's a number of different strategies under that grant. We here are concerned with strategy 6, which is to improve the knowledge of healthcare professionals about the best available evidence on dementia, caregiving for persons with dementia, and tools and supports available. So this is the year 1 plans for the grant. The grant year started September 1st. October 1st. So we're just at the beginning of year 1. And we have 2 strategies, or 2 activities that fall under what we're doing. So one is identify, adapt, and disseminate to 5 pilot sites the appropriate assessment or screening tools and supports for dementia and caregiving for persons with dementia using the provider clinical practice tool as a guide. We have changed that to 3 sites. The CDC reckoned that we were being quite ambitious for the number of our strategies, so we're trying to make sure that we are successful. And you can see the measures there. So the number of tools identified, the number of sites implementing the protocols, number of patients screened and referred, number of primary care providers implementing the protocol. And then 6.2 is to develop or adapt and disseminate a protocol for primary care providers on dementia assessment and screening and referrals at 3 pilot sites. So the finalized protocol is one of the deliverables for the grant. So it's great. So we can do something that's going to benefit the state as well as that's going to meet the grant requirements. So so this is the basis for last meeting. We talked about starting to develop a work plan for the next several months. These 2 activities are the basis for our work plan. I don't have a fully mocked up work plan yet, but you see we have until basically the end of September next year to get both of those underway. So I'd love some suggestions for the 3 pilot sites from this crew. I'm guessing what one might be.
So we haven't chosen them yet, the 3 sites.
No, we have not.
Yeah.
This is Kim. I'd recommend a medical home model if it's primary care. So a primary care with medical home model. They usually have a social worker, and that social worker could be integral to maybe even being trained in
Primary
dementia.
care with, sorry, the medical home model, did you say?
Yes, is that the right wording? I think.
So as a way of adding on to Kim's comments, I know when Kyle Allen was still with us, there was talk of taking a primary care practice and reinventing it to look more like a medical home, so that you would have a social worker there, you would have a geriatric care manager there, you would have the model of how primary care ought to interact with individuals who had cognitive impairments. Is that what you're referencing?
Correct. I just got off a 4-hour training. I was training the director of quality care introduced me to a new, I guess, social worker who's, or care coordinator at our Hydenwood primary care. Just thinking of people like that who they actually have someone extra to reach out, and if not just telephonically, monthly to their patients. Just workflow wise, what kind of office could adapt and have that workflow?
Is that the only one so far, Kim?
Oh, no, I think that perhaps Anne could give us more within Riverside, but I believe also Centera and maybe even UVA's clinic.
Yeah.
Although that might not be primary care, if this has to be primary care.
Hi, it's Vicki Armstrong. Just a few comments about the goals. So 6.1, identify, adapt, and disseminate to pilot sites. Riverside has a memory care coordination group that is working on essentially the same thing. And we are going to pilot this kind of a program in the Williamsburg area. Denise, I think you could probably help provide some details about that, but it's working with the primary care practices in Williamsburg to help them to be able to identify and adapt, evaluate the patients using clinical practice guidelines for, assessment of people with
I think, I'm not sure where we actually are on that, Vicki, but it is something that we're talking about. I don't know how much of that is, I think the thrust is to get the primary care providers more tools to be able to do that initial evaluation. I think send them on to either geriatric assessment for Fuller or to neurology. I mean, I think my sense, and I might not be completely clear on this, is help them be more sensitive to picking up when there's a problem.
And I think, if I'm recalling correctly, that the goal is to try to get that pilot in first quarter of 2021.
I think you're correct. I think that is the goal. I think you're remembering that correctly. We're getting closer and closer to that date. So.
That is true.
I know. So yeah. I'm not sure which practices have been identified in Williamsburg, if it's all the PCPs here or one or two practices in particular. I'm not real clear on that, Vicki. I don't know. Do you have a sense of that?
I actually don't. I know that the primary care practice director is working to identify those practices, but looking at this 6.1, I think, I don't know if we could use that as a pilot site, if that would be appropriate, but I just wanted to let the commission know what is happening.
Yeah, thank you for doing that. That's great, Vicki.
Can I ask, is that part of the ADPI project, or is that something that is separate?
That is separate.
Okay. So I'm not sure whether I can't remember how much actual funding I've asked for this. I think maybe just some money for printing costs and a bit of marketing. So I'm not sure that we would be able to provide funding necessarily, but if we can piggyback on your pilot, that would be super helpful. So I don't know if that's something that would be acceptable, but.
So I feel like we should have someone from our admin team get in touch with you.
Okay.
to
Yes,
help,
please.
kind of coordinate and see if there's opportunity. Would
Vicki,
that be?
is that Mary Martha?
Yeah, Mary Martha's on that task force.
And
And
Teresa
Sandy Snap.
Farley?
Sandy Snap.
And Michelle Wooten.
Right.
I was thinking Michelle when you guys were discussing that. Either Michelle or Sandy Snap would be the ones that either or both, to go to with about this.
We could brainstorm further afterwards with Michelle. I know she also wanted to bring a rural area like Gloucester in.
It's interesting you said that, Kim, because George, that's what I was going to say, is that as we think about the sites, that there's both a rural and a urban site, and maybe we even think about Northern Virginia. I don't know. I just was thinking about widespread.
Yeah, I definitely agree with that, Rick. I was thinking maybe somewhere in Southwest Virginia, and either Hampton Roads, Tidewater, Williamsburg area, or Richmond or Northern Virginia for the more urban ones. And I also wanted to talk to Dr. Manning about whether there was any potential at UVA, because UVA primary care they have a number of quite rural offices, and so that might be easier to do than Southwest Virginia, although I would like to get that geographical spread.
Yeah, I think when you talk to Dr. Manning and the work she's done on the grants, that they've made significant advancements in some of these very things we're working on. And you're right, they've got rural branches, and so that could be very fruitful.
Yeah. So I didn't mean to. I certainly don't want to impose on what you're already doing at Riverside, because it sounds like a really great effort. But it'd be nice to certainly maybe talk to the task group or something to share what we're doing and make sure that we're kind of doing something similar. As far as like recommending which screening instruments to use and stuff, I mean, there's a number out there, and I guess we want to provide a bit of a suite so that the primary care doctors can choose something that suits the way they practice. At the same time, we don't want to give them so much choice that they're a bit lost over which one to choose. So maybe 2 or 3. So I was thinking the 88, the MoCA, and the DFA website, Dementia Friendly America website, has some training videos for the slums as well, and also for the mini-cog. But my understanding is that the mini-cog is maybe not used so much anymore, and I never hear of anybody using slums. So
Yeah.
So actually, the mini-cog is used in all of the Medicare wellness visits. So theoretically, it is used for every patient over 65 at least once a year. As a screening. And slums, I see it used occasionally.
Mm-hmm. Okay.
Yeah, I would.
So I guess the mini-cog 88 MoCA. In that case, sorry, Denise,
and
I
slums.
didn't mean to interrupt.
The problem with MoCA is that you are supposed to be MoCA certified, and not everyone's going to do that.
Right. Yeah.
Yes, that was another question I had for you. So is that something that we want to include, or just make sure that we put a note that certification is required or something for MoCA?
I think
in that.
Yeah,
I think
would recommend
indicating that there is certification for MoCA would be the appropriate thing to put there. So, and just a comment, I think working together to see what we're doing, is great. And just a clarifying question, do you want either Sandy or Michelle to contact you, George?
If they wouldn't mind, yeah.
Okay, all right.
If that-
I'll set that in
that's
motion.
easy.
Okay,
Thank
Thank
you,
you.
Vicki.
One of the things we
Um,
talked about was time primary care has to devote to that. Does that make a mini cog more preferable than a MOCA, or is a MOCA likely or not likely to happen based on the time primary care has to devote to this? Vicki?
I think there's a time issue. There's also the component of certification and training for MOCA administration.
Yes.
Did that answer your question?
I guess, I mean, I have a question about the 88 in that case. So is that, are you all familiar with it? Is that something that is used at all in Riverside, or?
Yeah, I'm not familiar with that one.
I am, we just don't use it.
Okay. Let me show you the 88. So this is, it's 8 questions, and they're just looking for, yes, there was a change, or no, there's been no change in
And this is actually
mostly memory.
Yeah. And this is actually aimed at not the person so much living with it. This is actually something more you might give the care partner. Because the person living with dementia may not have any insight. They may think their judgment's just fine, they're not having problems. So you can administer. I just don't like it as a tool. I definitely have a biased preference for the MOCA because it is evidence-based, and I like the fact that someone has to be certified to give it. So there's fidelity, and the interpretation is done correctly, the way it's administered is correctly. So you have consistency in the way it's done. So I have several reasons I have a bias towards the MOCA. I also like the MOCA because it has several different versions. It's available in different languages. So that's just my 2 cents worth on that one.
No, I would second all of that.
Yeah. So I'd agree, definitely. I think the 88 has a slightly different rationale, which is that it really is just a screening instrument. And so if there's a certain number of yeses, then that person should be referred to a full cognitive workup. And so this is not meant to be an assessment of any sort, really. It really is just a screening tool, whereas the MOCA is more, there is an assessment, and you can record that for changes over time, which I don't think you would with the 88 necessarily. So my understanding of what I've heard is that it's really aimed at general practitioners who don't have any specific training in cognitive stuff, and it's meant to be able to be done in 3 minutes. So, but I have no idea how much it's used in Virginia. So, but I think it might be a valid option for some practices, at least as long as they're making that referral afterwards. But I do agree with you in terms of the MOCA. It's a much better instrument, but it's trying to do something slightly different, I think.
As a screening tool to trigger further evaluation, it probably definitely has some value.
Yes.
Yeah.
I think that we have to keep that in mind, folks, is that we probably have to be fragile and adaptable. And what I mean by that is, in certain areas, Vicki, you've got access to a memory clinic or a geriatric assessment. You've got access to UVA, but in other areas you do not. And so, for example, in the areas where you do not and primary care cannot refer for differential diagnosis, how are we equipping them? To George's point, if you're primary care in an area that can refer to GAC or memory disorder clinic, perhaps all we're really looking for are warning flags and indicators. Well, so what I'm getting at is if you got to serve both of those populations.
Yes, that's definitely a valid point. So I think in whatever materials that we provide, that it needs to make those distinctions clear among these tools.
Yeah. So George,
and one thing, sorry.
One thing that occurs to me when we're talking about the screening tools, if you were to, I think the slums over the 88, I don't think it's a little bit more straightforward. It's not looking at cognitive domains to the extent that the MOCA is, but it's really actually testing cognitive levels. This doesn't really look at cognitive levels. This is just saying, what do you think about how you are? And one of the things that we know, I think Vicki and I can both tell you that we have people that would say they're just fine, all these things, and they're pretty impaired. So I'm not sure as a screening tool, I could see where it could potentially maybe in an earlier stage have value, but I would go to slums. My personal preference, I would go to slums over this.
Okay. It seems to me a little bit similar to some of the questions they ask about subjective cognitive decline on the Burfus. So it's, but if you're answering yes to those questions on the Burfus around subjective cognitive decline, you should probably be getting a referral to go and talk to a doctor about your cognitive issues anyway. So, yeah, okay. So do you have should we not offer? Is this something we can talk about down the road, or?
George, I'm sorry, I didn't hear the question.
Should we not offer the 88 as an option? Do you think it's?
I think it would be.
Value we're looking for.
I think it would be fine to offer it as an option in primary care.
Okay.
Although again, you know, I would think because of the Medicare wellness visits and the use of the mini-cog, probably more practices are going to be familiar with that. So it's probably, mini-cog is probably preferred as screening, but this can be used as well. And particularly if it's aimed at, does it say whether it's aimed at the patient or a family member?
It is preferable to administer the 88 to an informant if possible. It may be administered to the patient. So
okay, so it's an informant.
Yeah.
Okay. That would probably be interesting, you know, probably to do both of them and see how they compare, but that's beside the point.
Yeah. I see a dissertation.
Yes.
Okay. I mean, my feeling is that it has some value, but when you talk about the mini-cog as being part of the annual wellness visit, that certainly makes sense. But if they're already doing if they are doing the cognitive component of the annual wellness visit, then they should be familiar with the mini-cog. So, and we do have some training materials that we can adapt for the mini-cog. This was the only one that didn't actually have any training videos that I could find. There was some explanatory, or there was some presentations about it, but nothing that specifically tells doctors how to use this. apart from this paragraph.
So, Denise, in the spirit of thinking about caregivers, in a utopian world, you give the AD8 to the caregiver and the mini-cog to the patient. For example, when they first come in, the nurse sits with the caregiver, patient goes off to see the doc, you give the caregiver the AD8, you give the patient the mini-cog. That's in a perfect world where there's time.
It's also making the assumption they haven't accompanied the patient into the exam
Yes,
room.
good point.
And that's where that's why we have the models that we have in memory care clinic and in GAC, that we have set it up so we interview the care partner separately.
Yeah.
So they're able to speak freely.
Yep.
Yeah. So I think that would be making the assumption they're in the waiting room and you giving them it's on a clipboard. Can you please fill this out for us and just give it back to us? It wouldn't take long for someone to fill out, but my only caveat would be very often they're with the care partners with the patient in the exam room, and that makes it a little awkward.
Yeah. And one thing that we had talked about, I think somebody asked last meeting whether Dementia Friendly America had approached Epic or I can't remember the name of the other electronic medical record company about getting some of these screening questions included or the clinical practice tools included in those electronic medical records. They have not. So, and I had a conversation with them about it, and it would be quite a large and significant undertaking, and they simply don't have the bandwidth for that right now. So, which is not to prevent individual health systems from requesting that, but obviously there's a cost involved. So.
And Vicki, that was part of what your task force, I believe, is looking at, is how do we amend medical records, Epic, within the Riverside Health System to incorporate and encompass some of these things. Is that true?
So I think there's a couple different levels to answer that question. So on a system level, we have incorporated several different versions of MOCA testing in Epic. But again, as you've heard on the Epic level, they don't have anything that's pre-packaged. So yes, we have done some of that so that we have the screening and documentation available. But again, as Epic as a product, it did not have that. We had to build that. Did that answer your question or comment?
Yes.
Okay.
And I also want to address Kim's question in the chat about contacting Teepa Snow and seeing if we can add her YouTube site as an educational and training resource. So we've had this discussion in the coordinated care work group about including third-party, non-governmental or non-profit sources in the Dementia Roadmap, and I think it's tricky. So so we're trying to limit. There are reasons involved with why we're not linking, providing links to private companies in that, and so I think Teepa's website would fall under that same restriction.
Thank you, George. That's understandable.
Yeah.
George, can we go back to the brochure and have people make comments about the title? Because I personally like it, but I'd like to hear what other folks want to say.
Sure.
I like Dementia Capable Virginia. Does that need to be hyphenated? Dementia hyphen capable?
That's a great question. So the way the ACL uses it, dementia capability, it's not hyphenated. It could go either way, Kim, I think. So on the dementia state plan, we do have it hyphenated. So as I was putting this together, I did try it hyphenated, and I'll stick a hyphen in and see what you think. But I thought it.
I think considering the audience, I think the title is appropriate. I think it's fine. I like it.
Okay. So I hasten to add that I am not a designer or anything. So clearly this needs some work and would go to our communications department to have some input. But so it's really more about just trying to get something together for look and feel, and provide a bit of information about the initiative, as well as the focus for this, which is the primary care.
I think it's really good to have it in a brochure form, because I can't tell you how much stuff I get in the mail that I look at the front page and then it goes in the garbage. So that's something you want to avoid, obviously. So this is kind of a, quick and, oh, this is interesting. And I can tell you, I bet most primary care providers and even specialists are not aware that there is a Virginia state plan for dementia.
Boy, Vicki, I couldn't agree more. And George, I think that's a big benefit, because in my wildest dreams, wouldn't it be great if all across the state, anybody doing anything for any patient or family member with dementia know those goals, and that's the bar, right? We're all striving. Yeah. So I love putting the dementia state plan's goals on that brochure.
Good.
Probably
yes,
measurable.
That was
the delay of getting to getting a diagnosis maybe decreased as we increase awareness of a plan in place, that we're working towards this, that there are resources. So we just recently actually just looked at research of reasons for delay in diagnosing.
What were some of those reasons?
Sorry. Well, the lack of resources, and that there is no cure, and that they don't know where to refer, what are the referral, what are lack of. I think this is part of the solution.
So one of the things, actually, now you've said that, one of the things that's not on here is any rationale for early detection and diagnosis. So would that be helpful, do you think, to have a short paragraph?
Absolutely, it would, because many physicians do view, well, you can't do anything about it anyway, which we know is not true. I mean, obviously I take a different, approach to that. And so I think that, state a bullet list of why it is important to identify memory problems early would be really valuable.
This is Kim, George, I'll just after the meeting, email you links to the articles too that we found.
Oh,
in
great.
case you want to
That'd be
refer.
great.
I think I
Maybe-
actually may have some of that information in a poster, in
Okay.
a bullet list that you
Okay.
could cut
I was
and
thinking
paste.
maybe an FAQ. So, you know, picking a couple of the main objections why, or main reasons why people aren't doing it, and posing it as a question and giving a short answer as to actually this is the rationale for. But a bulleted list, I'll try it both ways and we can see what we like.
The FAQ or bullet, they both sound like a simple approach, which is good.
Okay. Do these three buckets. So thank you for the input on, I guess, the initiative name. So the hyphen thing. So we'll continue that discussion, I think, in the full commission, but I just wanted to have you thinking about it. Now, my worry is that now that I've put Dementia Capable Virginia out there, everyone's going to say, yeah. So that maybe I should have put nothing and had everybody come up with their own ideas, but it does capture what we're aiming for. So, and it ties in with the state plan, building a dementia capable Virginia. And so I do think it has value. As far as the buckets go, the training, resources, and referrals, is that what we're looking for, do you think, or could these be better organized or differently organized? It's going in a way that's going to speak to the providers and their practices.
Kim, I really liked it, but I'd be interested, Vicki, from the provider standpoint.
So thinking again from a primary care point of view, where, you know, you have 10 to 15 minutes for a patient, I think, again, you know, having, you know, kind of the quick and dirty information you need at your fingertips is very, very important.
So is there anything that you think is missing from this?
I don't know if it could fit, this is Kim again, but support, whether it's spiritual, therapeutic, for the caregiver, for the person being the patient, the care partners. I'm thinking of the Care to Plan through the University of Minnesota, how it has buckets, and some of that is how do you deal with difficult behaviors and manage a new and just going through with a therapist. This isn't what we planned retirement looking like. So this is very diagnostic, provider focused, but connecting with that also.
Well, and I think what you're getting at, Kim, is, you know, really, you know, beefing up the referrals and, you know, referrals for what? So the community organization, the Dementia Roadmap. So those kinds of, you know, say categories of referrals, you know, maybe. I think that would, you know, kind of help, you know, really round out.
Categories of referrals. Thank you. Yes, it's under
Yes.
referrals.
Christy Judson
I
would
see.
be very happy with you, Kim, that we do something to bring attention to the plight of the care partner, the caregiver, so that if nothing else, you get the doc thinking about it's not just the patient, it's the care partner, caregiver, it's the whole family. So I think Christy would really appreciate that.
I'm glad that groupthink can rub off working together.
George, I got a quick question about the Dementia Roadmap. Is this based on the one that Washington State did, or are we developing a different tool?
No, it's an adaptation of the Washington State one.
Okay, because that's a great tool, and I give that a lot.
Mm-hmm.
When we're looking at referrals, would it be appropriate to add links to some online resources here as well? I'm thinking of some places that I use a lot of their material. The Family Caregiver Alliance has really good information available that would be beneficial. Just a link to keep us know. There are some apps for your phone that you can put on that you can pull it out and take a look at this behavior and like, how do I manage it? So I'm just kind of wondering, is there any reason we couldn't include that on here as well? I'm thinking as a resource for people, because I'm thinking in terms of the resources we give our care partners in both the geriatric assessment clinic and in memory care clinic. So just kind of wondering, is there any reason we can't think beyond call this person, or here's a handout for you?
So the short answer to that is no, there's no reason. We can certainly consider things. One of the things I'm concerned about is keeping this really razor focused on the practice and the provider rather than the consumer, or the patient or the family or individual. And my kind of goal within this initiative is to have that Dementia Roadmap be the gold star reference for that practice would then provide the patient with. It has, so we've added a few things. We've added a section on caregiver self-care in that Dementia Roadmap, because that wasn't there, and the caregiver's 10 commandments and some plenty of resources for caregivers themselves, in addition to what's already in that excellent product. So I think we would just need to keep in mind who the audience for this is. So this is really aimed at the practice and kind of wanting to trigger the practice into thinking, oh, these are some great things that we could then give out to the patients, rather than saying, this is what you have to give them, but here's some. It's like, well, they've given us some ideas of things. So if I can give that to the patient, that might be at least a start. I guess what I'm trying to help change is that story of, I went to the doctor and he said I had Alzheimer's and said come back in 6 months, but didn't give me anything else. And so we maybe we put essential resources for the patient or something like that, to say these are the things that you should give everybody who's got these cognitive concerns, and maybe some additional ones. But I'm a little wary of getting too consumer focused on this product.
Understood. This is Kim with Care to Plan, which is a research project also, as you know, with the University of Minnesota. We try to just limit it to 3 referrals based on their specific areas to address in a care plan. And we found the area Agency on Aging, the Alzheimer's Association, we were leaving out many people are veterans. So I don't know, just a reminder that the veteran resource for veterans, if applicable, maybe an asterisk, but
Maybe
Veteran
Veterans Navigator.
Or the VA, but
yeah.
Well, Virginia Navigator includes veterans and senior. No.
Yeah.
Yeah, there you go. Good. Mhm.
Yeah.
And caregiver support.
But George, I support your note, your thoughts about concise time restrictions of primary care, not giving them too much. To Vicki's point, you give them too much, it gets rolled up and tossed in the trash can. So I support your thoughts on that.
Yeah, so I mean, the idea would be that along with the brochure and that we would actually be able to provide them with some hard copies of the Dementia Roadmap at the same time, and also some materials from the Alzheimer's Association, so they would have a pamphlet, a rack card or something to give families with the helpline number, and also a rack card or something from the local area agency on aging, so that the practice itself wouldn't have to do that work. Does that sound like? I mean, that's the hope anyway. I'm not sure that everything will be available on. It should be roughly around the same time. Yeah.
With Dementia Capable Virginia, can that be created into a branded type of logo? Even just maybe hands around the side?
Definitely.
Something on, like the DARS logo, but.
Yeah, I was gonna just get our communications folks to put together some ideas of logos, to generate some logos that we could discuss.
Oh yeah, sorry. Like the outline of the state of Virginia, or D in dementia could be a brain.
Can you put these down on paper and send them to me?
Oh really?
So, yeah.
Actually, I like the Virginia outline.
Yeah. So the hope is to have a few logo ideas that we can throw around at the next commission meeting as well, as part of that branding discussion. But those are great ideas, Kim. Thank you.
George, are there other decisions we should make or information we should provide in regards to this brochure and the actual package, or are you feeling pretty good about what we're giving you so far?
So I'm going to send this out to you now after the meeting, and if you have some further notes to make on it, that would be great. I've got everything in here that we've talked about at our previous meetings, and added a little bit, mainly around the referral side of things. So this is definitely a work in progress. I would hope to have a kind of finalist draft of this by our next meeting, which will be January, February time, and then we'd look to have it finalized ahead of the June commission meeting. That's my kind of timeline for the Dementia Roadmap as well. And what I'm going to do is, I don't know how I'm going to do this, but somehow either put a little mock-up website together, a web page together that has that looks enough like the brochure that if somebody's going from it, they can translate directly to the links on the screen. Does that make sense?
That makes a lot of sense.
Like a similar layout. So whether that's on All's Possible or somewhere on the DARS website is yet to be determined, but somewhere where we have the links to all these different training videos and stuff and the tools themselves. So, but yeah, so I think what I want from your homework, if you choose to accept it, which I hope you will be to think about the pilot sites, and if you have any great ideas of folks that I can contact, that would be great. As I said, I'm going to talk to Dr. Manning, but so for example, I think it would be useful to have some sites, as Rick said at the beginning, that may not have those connections to the memory assessment clinics and neurologists. So some a little bit more remote, where this would actually be filling a gap that perhaps they didn't even know needed to be filled.
Would it be okay if I showed this pamphlet to a primary care provider to get an impression?
Absolutely. Yep. Yep, that would be super. Thank you.
Okay, great.
And Vicki, you're going to have Michelle and or Sandy reach out to you.
Yes, I will introduce you all by the way of email.
Okay.
Perfect. Thank you, Vicki. So I appreciate everybody's feedback and thoughts on this so far. And as I said, if you've got anything in the meantime, over the next few weeks, please shoot that feedback or thoughts back to me, and I'll incorporate them for the next meeting of this work group. But I think we're on the right track. So I appreciate everybody's help with this so far.
George,
And, yeah.
On the next item on the agenda, outreach, dissemination, I had a conversation with Christy Jensen this morning about the microlearning lessons, the 5 microlearning lessons developed for primary care. As you know, they were developed through ACL funding. And the good news, it's preliminary good news, but she tells me that there are discussions going on at this very moment that you may be aware of with Ed Ansello, VCOA, and Virginia Navigator, to making those 5 micro lessons for primary care available on the Navigator site as early as January. So we may soon have a way to disseminate those across the state.
Great. Okay, that's really excellent. So I wasn't aware of that, but I would be happy to reach out to Adrian Johnson and Dr. Ansello and see if we can maybe build this into something incorporating what we're doing.
The other thing I learned today is that there are also, and by the way, Denise and Kim, butt in anywhere I go astray. There are also 10 micro lessons for caregivers that were developed pursuant to the present ACL grant SEAL has, that are already on the Virginia Navigator site. And even though ostensibly those micro lessons are for caregivers, Christy advises me they're pretty good for RNs and other staff as well, and they're already available. Yeah. Is that right?
Yeah.
That's correct. Yeah, it's based on the Rosalind Carter Caring for You, Caring for Me. And this is dementia specific, and you're aware of, I think you're pretty aware of this, Caring for You, Mind, Body, and Soul. And there are 10 lessons. It's on the Navigator microlearning, and they're 5 to 10 minutes a piece. You can watch them at your leisure. You can binge watch the whole series if you want. You can always go, and the nice thing is you can always go back and review these at any time that you want to. So, yeah, that's a recommendation that we give to again in both MCC and geriatric assessment clinic. Give that care partners that information so they can access that.
And George, one of the things Christy told me this morning, which will be a challenge to us no matter what kind of platform we use, is that what they're discovering is that people go into the lessons and they watch 1 or 2 and then fall off. So as we think about whether it's the 5 for the primary care or the 10 for the caregivers, we have to think about motivational interviewing or some kind of way to keep them engaged. Or they're likely to watch 1 or 2 and fall off.
Yes, although I'd say there's definitely some benefit in them having watched those 1 or 2.
Absolutely.
We'd like them to watch all 5. And they are available currently on the All's Possible website. So
Oh, good.
they're freely available, but again, it's a lack of knowledge about them, the same as the state plan or All's Possible generally. We haven't done serious outreach to primary care providers to get them to come to that site. So I'm glad to hear that they're going up on Navigator. I think that'll be really great. And the caregiving, the caring for you, caring for me, caring for you, mind, body, and soul. Those are included in the Dementia Roadmap for family caregivers. So certainly, I agree that nurses can benefit, and there should be some cross-pollination between consumers and providers. But I think the primary focus, anyway, is the caregiver. So I think having including the Dementia Roadmap kind of embeds those caring for you lessons in this as well.
George, it does speak to the larger issue as we talk about dissemination and outreach, which is the age-old question, how do we get the word out there? And at the last meeting, we talked about the large health systems and champions within those large health systems. And obviously me, Vicki, and Cam and Denise can talk about Riverside, but obviously we have to find ways to get those champions within Bon Secours, Centera, HCA, all the systems throughout the state. And honestly, George, I don't even know where to start, but
yeah,
you guys have some influence.
So I did speak to somebody at Ballard Health in January who Ballard covers Southwest Virginia, and they had hired somebody to kind of pull together dementia services and help improve the dementia capability of the hospital system. Of course, that was just as the pandemic struck, and I haven't done anything further with them, but that would be somebody to talk to. But yeah, so I agree, there needs to be champions. And I know of several in scattered systems, but I don't have a list of this is who I should be talking to in every health system. But so if you guys have some ideas, and also, your word of mouth is going to help share this and disseminate it and provide outreach. So I think that's one of the things that we'll be discussing at the commission meeting on the 8th, as well as the role that every commission member can play in getting the word out there. So, and that in addition to everything else that we will try and do to get the word out.
Also, that there was a rural health advisory committee for Virginia, maybe connecting with other state initiatives.
Sorry, I'm not familiar with that one.
Yeah, I was on it a few years ago and then it kind of ended. So I have to see if there's still one or.
Okay.
Yeah. Or if the initiatives were met and ended, I don't know. I can't imagine.
Okay. Was there anything else that you wanted to say about dissemination, Rick? Did Christy have any other bright ideas?
Just that, and maybe this should be part of our homework as well, George, is that, as you mentioned, we all have connections and we all have individuals that we can think of, and we can begin to record those thoughts, send them to you, present them at the next meeting, because that is often the key to our success, is we have these wonderful ideas, people who need it, and then the bridge over which we must travel to get the word out, and it's tough.
Yeah. Well, I certainly appreciate any ideas you all have. So.
Well, I think obviously in this coronavirus and pandemic, and now with vaccines coming out, I think that our message is going to be overshadowed by all of that for probably the next 6 months, I would at least bet.
Yeah.
Sad but true.
So that's yeah, it certainly is. And that was kind of built into our timeline a little bit, in that we're aiming to have most of these things ready by September next year. And so hopefully the vaccine dissemination structure will be set up by then and functioning in a way that they don't have to, not everybody has to devote all their mental energy to it all the time. So, so I think but in terms of the pilot site, so we do need to identify those three early. So I'd say we should have some candidates by our next meeting in January or February, and with a view to that pilot starting in September-ish. When hopefully people will have the energy to think about something other than COVID.
Very good.
Not to downplay it.
Yes. We covered most of where you wanted to go in this meeting today. We're approaching the bewitching hour. Yes.
Yep.
And have we picked a date
yes.
for the next meeting?
We have not. So
Should we?
Do you want to do that now, or would you like me to send a doodle?
Let's do the doodle. Yeah. Let's do the poll. Yep.
All right. So I'm thinking late January, early February time.
Sure.
Okay. And then much of, some of what we've talked about is we're going to continue that discussion in the commission meeting. So Denise and Vicki, I'll share that information with you guys once that's passed. But after this meeting now, I'll send out the brochure. Is there anything else that you'd like me to send of those materials that I showed you, or anything else that I've talked about that you'd like to see again?
Clarification, you're going to send the goals for the BOLD Act, that slide?
Yes, I can send that as well. Yep.
Yeah, that would be
Yeah.
helpful.
Yep.
Super.
George, we should know by the next meeting whether or not, in fact, the 5 primary care lessons will appear on the Virginia Navigator site. We should know by then.
Okay. All right. Good.
Oh, and if ever we should like it or believe that it's beneficial, I can certainly get Mary Martha Stewart or Christy to join us online and talk briefly about, or in as much detail as you'd like, about the microlearning lessons.
I feel like everybody who's on today is well versed in the microlearning, but and we've talked about, I think Mary Martha did I know she did a presentation for the Caregiver Coalition, but I think she did one for the Alzheimer's Commission on
did.
the micro ones a couple of years ago.
Yeah.
But it might be worth refreshing. So yeah, and certainly the folks that aren't here today that are in this work group would not be very familiar with them. So
Yeah. And as you know, she often will show you one. So she not only
Yeah.
describes it, but you get to experience it. Yeah.
oh yeah, yeah. That she made. She told me when I first came on board. She said, "Well, you can't talk about it. You have to see it." So,
All right.
great. All right. Well, thank you all for your great thoughts and input today. I really appreciate it.
So unless there's other information for the good of the body, we're probably going to adjourn this meeting. You okay, George?
Sounds good, Rick.
So adjourned. Y'all take
All right.
care.
All right. Thank you
Thanks.
for
Happy
stewarding.
holidays, everyone.
Same to
Happy
you.
Thanksgiving.
You too. Bye-bye.
Bye-bye.